Hello, everyone. Thank you very much for joining. We will just give another minute for more folks to join, and then we will go ahead and get started. All right, so it is 1 minute after the hour, so we will go ahead and get started. Good morning, good afternoon, everyone, and welcome to today's webinar, which is hosted by Hepatitis Delta Connect. My name is Beatrice Ovich, and I am a Public Health Program Manager at the Hepatitis B Foundation and Manager of Hepatitis Delta Connect. Thank you all for tuning in today. Today's webinar is focused on the European profile of hepatitis delta and the landscape of Bulevirtide on the continent, which is also known as Hepcludex, and is the first drug in the world that has been approved for treatment of hepatitis delta and has recently been approved for use in the whole of Europe. We will have an opportunity today to hear from experts in 5 different European countries who will share about the prevalence of hepatitis delta in their region, challenges with diagnostics and management of the virus, and how Bulevirtide is changing the landscape of HDV in their area, and insights on any unmet needs that remain with the virus, as well as ideas on how to address these. We look forward to a robust discussion. Next slide, please. Thank you. So before we get started, I would just like to remind all participants that during today's webinar, all audience attendees are muted. We encourage you to use the chat feature to let us know who you are and where you are joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. At any time during the presentation, you can enter questions you might have into the Q&A box, and questions will be addressed at the conclusion of the panel discussion. This session is also being recorded and slide presentations will be shared following the webinar. Next slide, please. Thank you. So just a quick overview of Hepatitis Delta Connect. This is a dedicated program of the Hepatitis B Foundation, which was established in 2016 for the explicit purpose of raising awareness about hepatitis delta and promoting diagnosis, screening, research, and linkage to care, as well as providing support to those who are living with and affected by hepatitis delta through a variety of channels, including email and phone consults, social media, newsletters, blog posts, a website, and webinars such as this one. We're hoping to continue to build and expand our programming through 2023, and we'll keep you posted about developments and further opportunities to get involved. Next slide, please. Thank you. So we are very excited and honored to be joined today by a diverse group of panelists who will share some of their insights about the rapidly evolving world of hepatitis delta in Europe today. So we'll be joined by 6 speakers altogether, and they are Dr. Philippa Matthews, who is the Clinical Science Group Leader at the Francis Crick Institute in London, United Kingdom, Dr. Stuart Flanagan, who is the Consultant Physician for HIV and Bloodborne Viruses Medicine and Honorary Associate Professor at the University College of London Division of Medicine and Hepatitis Lead at Central and Northwest London Trust, Dr. George Gerlan, who is the Head of Infectious Disease Department 4 at Dr. Victor Babes Clinical Hospital of Infectious and Tropical Diseases in Bucharest, Romania, Dr. Pietro Lampertico, who is the Director of the Gastroenterology and Hepatology Division and Head of the AMEA Magliavata Center for Liver Disease at the Ospedale Maggiore Policlinico, University of Milan. Dr. Tariq Assala, who is a full professor of medicine and hepatology at Hôpital Boujon in Clichy and University of Paris, France, and head of viral hepatitis at INSERM, and Dr. Teresa Casanovas, who is the president of the Asociación Catalana de Pacientes Hepáticos and board member of the European Liver Patients Association and coordinator of ELPA's scientific committee in Barcelona, Spain. So we're very excited to hear from our panelists today and are grateful to them for joining us. We'll begin with a brief presentation from each panelist about the epidemiology of Hep Delta in their country, followed by an open panel discussion and concluding with questions from the audience. And we invite all audience members to put any questions you may have in the Q&A box. And without further ado, we will get started. I invite Drs. Matthews and Flanagan to begin sharing your brief presentation about HDV in the UK. And next slide, please. We can get started. Thank you so much.
Thank you very much, Beatrice, for the kind introduction, and we're really delighted to be invited to participate in this discussion, which comes at such an important moment for patients with hepatitis delta infection, and also for their clinicians and for researchers interested in this field. So you've clearly introduced us very nicely. Just to say, Stuart and I are both clinically active, providing care for people living with hepatitis B, delta and HIV in the UK, and I also work internationally with colleagues, particularly in South Africa, and Stuart and I have overlapping research interests based in the UK as well. Next slide, please. So just to kind of set the scene for hepatitis delta, I'm not going to spend a lot of time talking about the virus as a pathogen, but more focusing on what we know about its distribution and treatment. But let me just say a very few words to set the scene. It's such an interesting virus. It's a tiny little virus that's called a satellite virus. And that's one of the reasons for this, is it can only cause infection in people who have hepatitis B infection as well. So the two have to go together. It's actually the smallest virus known to infect mammals, but it's estimated to cause a lot of liver disease, and that's partly because of the numbers of people who are infected with the agent, and also because it's a very potentially aggressive pathogen that increases the risk of long-term liver complications. You can see here the estimate is actually between 12 and 70 million people worldwide, and that's quite a wide estimate, and that shows that we don't have a lot of confidence at the moment in the numbers, and I'm going to go on and explain why that is. So if you could advance the slide. Thank you. So on this table, we've got basically three categories of reasons why there are challenges for hepatitis delta. And Stuart and I are particularly focusing on the UK, but actually I'm sure that you'll find as our colleagues from elsewhere in Europe speak that some of these characteristics are held in common. So let's look at the first column, epidemiology. So hepatitis delta is a neglected condition, by which I mean there has not been really enough focus or investment or advocacy on this disease. And so we're missing some of the information that we really need. And now is a great time for us to really put more resources into doing this better. We know that hepatitis delta is commoner in certain groups, and these include, in some cases, populations who are not well served by existing healthcare. And that may be because of where they live in the world. It may be in some cases because they suffer other social disadvantage. And also this may change over time. So the populations who are most affected by Delta virus may have changed and still be changing over time. And in the UK, we know, for instance, that by region, there are differences in how common this infection is. If we think about the laboratory tests, there are problems because the availability of laboratory tests is not consistent. This certainly applies in the UK, where some hospital laboratories will offer the testing and others won't. And it certainly applies across the world. And my international research has definitely found that this is difficult. There are actually two laboratory tests that we do. We measure the antibody, which tells if you've been exposed to the virus at all at any point. And then we also measure the virus's genetic code, that is the RNA, and that tells us if someone has actively at the present time of the test got current infection with the virus. But not all laboratory tests run either or both of these tests, and also they can take quite a long time to report back. So even when you ask for the laboratory test, you can be kept waiting quite a long time to get a result. And that can be really problematic, and particularly for mobile and migrant populations, that can cause problems. And so we really need rapid diagnostic tests, and we've all come to understand what a point of care test means as a result of COVID. So it means a quick test that you can do with a finger prick, for example, that will give you a quick and result that you can act on right away. And then finally, a challenge is around guidelines. And one of the problems here is that we haven't had consistent guidelines on testing for hepatitis delta virus. And lots of the details that are provided to clinicians are just recommendations. And so they're not really clear guidelines. And that means that practice can be very different in different places. It also means that many people living with hepatitis B virus who are potentially at risk of co-infection with Delta virus either don't get tested at all or only get tested once during their lifetime. And so we're probably missing a large number of infections. Next slide, please. So I'm just going to talk briefly on this slide about where we might get more information. So one of the interesting pieces of activity going on in the UK is called the NIHR Health Informatics Collaborative. And this is a big infrastructure that allows us to collect routine clinical data from lots of different hospitals. And they're labeled on the map on the right-hand side of the slide there. And allows us to collate these and reuse them in an anonymized form for research purposes. At the moment, we've got data for about 14,000 hepatitis B patients, but we've only been able to collect information on 88 people who are known to be Delta virus positive among this group. And this is really likely to be an underestimate, and that reflects what I've said about testing, which is that we're not testing enough or consistently enough. However, there is some clear testing guidance from the British HIV Association, BIVA, so we do have better data for hepatitis delta virus in people who are living with HIV and hepatitis B co-infection, and Stuart will talk a little bit more about that in just a moment. If you can just advance the slide. The final point for me to make here about more information is that we're excited about a new hepatitis delta registry that's being established across the UK. And this is really a route to try and make sure we've got consistent data, that we're encouraging clinicians to test, and that we've got a central database so we really can understand better the case of need for these patients, where they are in the country, how many people might be eligible for treatment. And that's really important as we get this new drug rolled out. So I'm going to pass on now to Stuart to tell you a bit more about data from the UK. So you can advance the slide here. Thank you.
Thank you, Philippa, and thank you also for the invitation to speak today. So yes, I'm just going to talk briefly about where we are with data in the UK around Delta virus. And I can say briefly because our data is a bit patchy, and I'd like to credit our colleague Dr. Ivana Carey from King's College in London for pulling together the data that's on this slide. So our UK Health Security Agency, which is really our sort of public health body for the UK, estimates that there's around 206,000 people living with hepatitis B in England, but there are confidence intervals there from around 160,000 to 275,000, so it's quite a wide range, but that gives us a prevalence in the adult population of about 0.45% of people living with hepatitis B. Amongst those people that are attending centres and having their care and are engaged in care in the UK, only a few centres are doing testing for Delta prevalence, and most of these are based in London. And as Philippa alluded to earlier, that is related to the availability of the lab testing for Delta virus, and where there can be reflex testing for people who have surface antigen positive hepatitis B, and we can then go on to test them for Delta antibody and RNA. So the estimated prevalence of Delta virus in the UK in people living with hepatitis B is anywhere between 2 to 8.5%, and that's from a number of studies that have been done, again, mostly in London, particularly in East London, where Prof. Patrick Kennedy and Prof. Graham Foster are based and have done a lot of testing and prevalence studies for viral hepatitis in that area. So we still really don't have a clear picture of just how many people are affected by living with hepatitis B and Delta co-infection. And if we could go to the next slide, please. As Philippa mentioned, there's much clearer guidance around testing for Delta virus amongst people who have HIV and hepatitis B in the UK, thanks to the BIVA guidelines. So there are around 105,000 people in the UK with HIV, and up to 10% of those people are also have hepatitis B, of which around 15% have Delta virus. And this is actually a log scale. So we start off with 105,000 people that have HIV. About 10% of them are also living with hepatitis B co-infection, and of those, up to 15% have HIV, hepatitis B, and Delta virus. And I think really crucial for these patients who have the three viruses will be the Delta treatment, Bulevirtide, which is coming onto the market now, because these people are particularly at risk of developing advanced fibrosis, cirrhosis, and at risk of hepatocellular carcinoma at an earlier stage, even compared to those people that are living with Hep B and Delta. And then if we go on to my final slide. So I'm going to finish off with some really great news, which is just this week, it has been confirmed by the National Institute for Health and Care Excellence here in the UK that we will be able to start treating people with Bulevirtide in the next coming months. So they gave us the green light a few weeks ago, and then just yesterday published the technology appraisal guidance. So we now have an idea of who we will be able to treat. And NICE have recommended that we should be able to treat people with F2 fibrosis or above, and those people who have not previously responded to pegylated interferon or can't have interferon-based therapy. So it's a really exciting moment for us here in the UK to be able to offer the new treatment to our patients. And then I think our next slide is just our wrap-up slide, Beatrice, thank you. So again, this is a really exciting opportunity for us as well to hear what's happening across the continent of Europe. And we'd be delighted to be in contact with anyone who wants to discuss more of the UK data, and certainly information sharing and learning will be really beneficial to all of us. Thank you.
Wonderful. Thank you so very much, Drs. Matthews and Flanagan. It was a really helpful overview. That's great news that NICE has approved Bulevirtide for use, and a great overview of the challenges, including just the need for more testing and reflex testing, and the incredibly wide gaps in prevalence rates. And also the work you're doing on the registry is very exciting. So I will now pass it on to Dr. Gerlan so we can get a little bit of the picture of hepatitis delta in Romania. So I think, Kara, if you want, you can stop sharing these slides, and then Dr. Gerlan will share his. Thank you so much.
I will start sharing my screen.
Thank you.
Okay.
Excellent. Thank you.
Okay. So first of all, I want to tell you a few words about Romania. Romania is located in the Eastern Europe. The last population count was made in 2021, and population came out 19,053,815 people. About half of the population lives in cities in Romania. Sorry. Okay. We have quite few data about the epidemiology of hepatitis delta in Romania. No data for the authorities, no official data, but we have a quite large study which collected data in 2011 and was published in 2015. It was a multi-center study conducted among chronically HBV-infected patients, defined as HBs antigen positive, patients above 18 years in 10 gastroenterology and infectious diseases centers, covering approximately 80 to 90% of the population from all geographical regions of our country. It included a significant number of patients, 2,761 HBs positive patients. And the prevalence of chronic HBV infection of HBs antigen positivity in adult in Romania is 4.4%, which means an estimated number of 650,000 infected people, so HBV infected people, not including the occult infections, only the HBs positive antigen. Well, the numbers that came out of this study are quite concerning. The HDV IgG antibodies were positive in 23.1% of the patients that were tested. I want to share with you that these patients were selected randomly. Actually, they were all the patients that presented at the included centers, all the patients that presented in established period were included and tested for IgG anti-HDV antibodies. And out of this 23.1%, patients with detectable HDV RNA were 16.4% from this total HBs positive cohort. Looking at the age group, we can see that the most affected population is the population from born before 1999. 1999 is the year in which Romania changed dramatically the regime from communism to democracy. And starting 1995 in Romania, the vaccine for hepatitis B was introduced in the national health insurance scheme. So from the group between 40 to 49, 20.9 were positive for anti-HDV antibodies. And the most affected group is the group between 50 to 59 years. Over 60, we had less patients because unfortunately, these patients tend to develop complications and do not survive very much after this age, at least until now with the treatments that are currently available. And on average, patients with HDV from our study tend to be older, more female, and urban residents. And the virological profile of helper virus, of HBV virus, it's with H antigen HBe negative and with an undetectable or very low HBV viral load. Another thing I want to mention is that there was a significantly higher percentage of patients with liver cirrhosis versus chronic hepatitis in the HBV co-infection group compared to only HBV infected group. And of course, in the group with HBV that had the Delta positive viral load, they had an even higher risk of liver cirrhosis. And just one more slide showing the currently available treatments in Romania. We have treatments for HBV. It's the same treatments that are available all over the world. It's entecavir and tenofovir. And we still continue to use Pegasus in some patients for the treatment of HBV, HBV only infected patients, but this is very low number. And for HDV, the National Health Insurance Company covers the cost for at least one course of Pegasus, of peginterferon alpha 2A, of 96 weeks, so two years, but is a response-guided treatment. So we have to check from time to time the evolution of the patient, the viral load, and decide if we continue the treatment or not. And regarding Bulevirtide, I will talk probably later, but in the most optimistic scenario, we'll have it available in July, and in the most pessimistic, so to say, scenario from October. Okay, so these were the data from Romania. Thank you very much.
Thank you so much.
Actually, I want to add one more thing. Sure. I have a data from the unpublished study, which is including quite larger number of patients. And actually, the incidence seems to be lower than the numbers. I think it was a bias when selecting the patients in that study, because, for example, we in our clinic, we have in monitoring currently 3,000 more or less 3,000 patients with HBV, and only 150 patients with co-infected with HDV. So the percentage would be that one, about 5%, not more. And this study that is going to be published shows that the actual HDV antibody positivity is about 6.6 out of the total HBV infected population. So it's not 23.1%, which is quite large. Okay, thank you very much.
Thank you so much. Yeah, that's great to know. And that, yeah, it speaks to the wide ranges of prevalence as well that are found in multiple studies. So thank you for your research. And that's very exciting that Bulevirtide is close to being approved in Romania. So now I think we'll pass it to Dr. Esela just to give a brief overview of Delta in France. And I think Kara can share the couple slides, and I will pass it to you. Thank you so much.
Thank you, Beatrice. Thanks to the Hep B Foundation to do this webinar. I'm very happy and pleased to be with you and to share experience in different countries. So I work in France as a hepatologist in the north of Paris. It's Hôpital Beaujon. And so I will provide you with some information for Delta in France. So first, around 5% of people living with Hep B have Delta co-infection. There is an estimation of 200,000 to 300,000 of patients with B in France, so around 10,000 to 20 with Delta. And there was this survey that has been done in France by the ANRS, which is the French National Agency for AIDS and Viral Hepatitis. So it's not, taking into account all the sites, all the hospitals, but only the linked with the NRS, which was 34 centers, and they identified around 8,000 patients with Delta. It was very interesting because then you have a registry, you know about the epidemiology, the natural history, and you have a fast link to treatment option. But I would like, with this slide, to give three most important messages. First one is for screening and diagnostic tool for RNA. Everything is reimbursed by the government with the health national security system for the patient. So the patient has not to pay for Delta, Hep B, HIV, Hep C test. Everything is 100% reimbursed. The second message is that for Bulevirtide, there was in 2020 the compassionate use of Bulevirtide. So we use it in several years. And in the beginning, there was restrictions like what it will be with the NICE in UK, according to fibrosis stage. Now there's zero restriction in France. We can treat anyone immediately with no papers if there's HDV RNA detectable. So all patients with Delta, ongoing replication, can have access to treatment. So because the government agreed that it's a rare disease, that any patient can progress to severe disease, and finally, the fibrosis evaluation was difficult. So there might be mistake if we don't make access to all candidates with Delta, which is okay now in France. And also, two mistakes that we want to share, two errors that we should not do for Delta. One is to screen Delta only in risk factors groups, like in IV drug users and migrants, because in our study, we will fail to diagnose 20% of the patients who know these risk factors. And I think it's a mistake, like for Hep C, if you want to go for elimination, you don't limit to IV drug users or patients. Anyone with Hep B should be screened as the EASL guidance proposed. Everyone with Hep B should be screened for Delta. And also do not hesitate to repeat the screening, this test, if there's no risk factors. The second mistake is when we speak about sustained virological response in Delta. It's very different from Hep C, so you can have late relapse. So we speak about the durable virological response. We need to measure each year HDV RNA. So even if a patient is treated, we should not say he's cured, but we have to follow him. He's cured only if there's HBS loss or seroconversion, otherwise we have to follow always the patient. So the next slide, please. The next slide is some data ongoing. You know, it's the NRS Bulevirtide early access programs. So in the beginning, there was 150 patients treated. And the doctors can treat with Bulevirtide alone or in combination with PEG interferon. So each doctor is free, it's democracy, to choose his treatment. And in this study, in the beginning, around half of the doctors treat with the combination from the beginning and half with the Bulevirtide alone. And you can see what is interesting, but it's very similar data. You can see the baseline characteristics. It's younger patient than when you see cohort for Hep C, 40 years old, many with cirrhosis, with advanced disease, but if it was the first compassionate use, now it's open for all patients. So then we will have also patients with mild fibrosis, but you can see it was patient with very active disease, high viral load, high transaminases, cirrhosis. Next one. And you can see the virological response, this very interesting declining of virology. And the goal is to have a low level of HDV replication in the best undetectable HDV RNA with normal ALT. And we hope that these surrogate markers will be associated with less risk of cancer, decompensation, etc. So we are very happy that in France now, there is the availability of screening, of diagnostic tools. We try to implement reflex testings. Bulevirtide is available for all patients with HDV RNA detectable. Any doctors, specialists, hepatologists, medicine, gastroenterologists, infectious disease can treat Delta. But we recommend that for initiating treatments, they discuss with the reference centers, with the multidisciplinary team, because it's a rare disease, it's a long-term treatments. So to get advice from colleagues. Next slides. And you know about this data with normalization of transaminase, which means less activity, inflammation. We know that Pietro Lampertico is with us today, has a very interesting data on patients with cirrhosis, portal hypertension, and a very good result of therapy. Next one. So finally, to close, the estimation of Delta is not very well known because it's a neglected disease. Available tests are not available everywhere. We know that Delta increases the risk of cirrhosis, cancer, decompensation. Previous treatment recommendation was PEG interferon, but recently, at least in Europe, in some countries, we have Bulevirtide. There's drugs in development, so I think there's a good message, hope, with the Hep B Foundation, with everyone, with all of you to try to cure that in the future. Very much.
Thank you so much, Dr. Estella, for that great overview. And I think you made really important points, especially about the compassionate use program and the need to test everybody and update guidelines so that they're not risk factor specific. That's something that still has to be done, especially in the United States. So thank you so much. I'll now pass it to Dr. Lampertico. If you just want to share a little bit about Italy and the profile of hepatitis delta there, that would be great.
Well, thank you very much for inviting me, and I apologize, I don't have any slide, so I will give you some data very briefly. So first of all, I'd like to thank the Hep B Foundation for organizing this meeting, and also I'd like to thank Tariq because he made several important points that are also very important for Italy. So I will briefly cover epidemiology, diagnostics, and therapy. In terms of epidemiology, a recent paper which has been submitted, a large multi-center international study, estimated approximately 300,000 S antigen positive carriers in Italy, approximately 10,000 antibody for Delta positive patients, and approximately 7,000 HDV RNA positive patients. Of course, these are rough estimates, and not all the patients have been identified in Italy. And in my view, probably we are still overestimating a little bit this number for several reasons. So very recently at EASL, we will be presenting the initial data of a large epidemiological multi-center Italian study collecting 700 of patients. And at EASL, we'll present the first data, which will show that the age of Delta patients in Italy is about 56. So we do have quite an older population. And most of the patients are males with cirrhosis, with abnormality levels, high S antigen levels, E antigen negative, genotype 1, delta, and on nuke therapy. But what is very interesting, because 50% of the patients that we see in Italy today are not Italian born, which does not mean they are migrants. They came yesterday from Africa, from another country, but they came in Italy 10, 20 years ago, mainly from East Europe. So 80% of the patients not Italian born with hepatitis delta are from East Europe. And that's very interesting because in this epidemiological study, we compare all the baseline features of the 50% of the patients Italian born compared to the 50% of the patients which are not Italian born. And there are, several differences. The median age of Italian born is 60 years, while for migrants is 43. Many more males in Italian patients compared to migrants, much more cirrhosis, much more liver cancer in Italian born than in patients not born in Italy. More liver disease, more ALT levels actually in the migrants patients, more S antigen levels in the migrants patients, and less oral therapy for B in the migrants patients. So that's really a unique situation, in Italy. Everybody born in Italy between the age of from 0 to 42 has been vaccinated for B. So formally, there is no Italian born younger than the age of 42 with either HPV and Delta. So young patients with Delta are barely only migrants, although they migrated maybe 10, 20 years ago to Italy. And the older patients are mainly Italian born. So that's maybe a unique situation for Italy. And again, the vast majority of non-Italian born are from East Europe and are genotype 1 of HDV. So in terms of diagnostics, I don't think we have a major problem with diagnostics in Italy. First of all, like in France, everything is for free for patients. So antibodies tests are available almost everywhere. Delta RNA, now for the Delta RNA quantification, the situation is better now than 1 year ago. Most of the big centers have a good, reliable, sensitive, and specific test and commercially available test. In each region, we do have a large reference centers. So if you don't have the test in your small center, it will be very easy to get the quantification done in the correct way. So I don't think this is a major problem anymore. Some of the centers are using reference test. For the last topic, therapy, as mentioned by Tariq, Bulevirtide has been used in Italy for almost 2 years. We were allowed to use Bulevirtide only as a monotherapy 2 milligram in patients with cirrhosis. We already published the data, is performing very well in patients with cirrhosis and esophageal varices with excellent virological responses, excellent biochemical and clinical responses. And the drug has become available for everybody with hepatitis delta for free, again, like France, from the 1st of May 2023, so basically 4 weeks ago. And after this deadline, now most of the patients of Delta already being identified in the reference centers are starting or will start Bulevirtide, mainly monotherapy, and maybe for some patients with mild liver disease, we might think about some sort of combination with interferon because of the excellent data provided by the French investigators. So overall, the situation with Delta has improved very much. And for us, for clinicians, for hepatologists, the wide availability of Bulevirtide monotherapy has been a game changer. Well, not only for us, but mainly for our patients. Thank you very much.
Thank you so much, Dr. Lampartico. That's great. So glad to hear that Bulevirtide will really will really continue to change the landscape in Italy. And also very interesting data about immigrant populations and the differences that you found in people affected in your research. So now finally, I will pass it to Dr. Casanovas, who is joining us she's currently in Brussels, but she'll share some information about Spain, and she will share from her perspective as being part of the European Liver Patients Association. So Dr. Casanovas, I will pass it to you. Thank you so much.
Thank you very much for the invitation to participate in this very interesting meeting. I'm very happy to be here on behalf of liver patients. Delta hepatitis is an orphan disease. So if we have 100 patients, it's a lot. So also Bulevirtide is an orphan treatment, and it was approved by the EMA on July 2020 for the treatment of chronic Delta infection based on data from phase 2 clinical trials and considering the lack of therapeutic options. Next slide, please. Next, please. We have to think about barriers, challenges, and gaps which are suffering our patients with hepatitis Delta in Spain. The situation with Delta hepatitis is special. It is a rare disease, is poorly known and underdiagnosed, does not have an alternative treatment. And the present situation is a situation of inequality and uncertainty because for the moment is not approved the treatment. Criteria should be that it is a serious disease, there is not alternative, and moreover, they cannot wait because it can lead to irreversible sequels. Next, please. Recently, on the 1st of June, this is our data in the recently created Spanish registry. This includes 213 patients with active follow-up and informs about epidemiological, clinical, and virological variables during evolution. Average age 52 years, 54% male, 57% born in Spain, and 21% in Eastern Europe. The main follow-up of 6 years. The estimated prevalence of hepatitis B in Spain is 0.22% to 0.50%. About is 90,000 people. And estimated co-infected with Delta are 5%. Considering patients included in the registry, 45% already had cirrhosis at the time of being diagnosed, and 19% had portal hypertension. During the follow-up, 11% and 15% developed cirrhosis and portal hypertension, which is a high percentage considering the short follow-up. Next. Yes, this 1st of June was presented in Barcelona, the conference How to Prevent Patients from Waiting 2 Years for New Orphan Drugs. Was organized by Pharma Industria in Spain, and they recognized that there is an urgent need to improve disponibility of orphan treatments in Spain. The law is different in each European country, and the average time for approval in Spain is more than 700 days. Patients do not have time when a new and effective medication has already been authorized in Europe and cannot be administered in their country. All the speakers, patients, academics, managers, politicians, agreed that the situation has to be improved urgently. Patients and families are living the situation with anxiety and uncertainty. Why Bulevirtide should be approved? Next, please. Based It is not only a question that hepatitis delta is a serious illness without therapeutic options. Patients cannot wait because the quality of life and survival without treatment will be worse, and the disease progresses with serious sequels and complications that are potentially irreversible. Patients suffer a situation of inequity, and how to overcome unmet needs of hepatitis delta in Spain. First, increase information, screening, diagnosis, assess liver function, control and treatment. Time needed to get access for advanced and innovative medicines should be shortened, not only for Bulevirtide. We need to consider other options in the pipeline. It is crucial to recognize the need of equity and transparency in the access to new medications in orphan diseases with the participation of patients in all the process. It is not only a matter of cost, but the health value associated at individual level and also a populational level that should be reminded. It is a complex issue, but should be solved, avoiding long-term decisions and uncertainty. Next, please. Our demands representing the voice of liver patients. What could be done to increase visualization and empower patients? We need more campaigns, updating information to professionals and healthcare teams and managers, accurate information about the prevalence of HCV, HBV, and also delta hepatitis in each country should be published. Take into account that hepatitis delta is a rare disease, therefore it has specific features, few numbers, and study methods, and this disease is clinically heterogeneous. A narrative of patients is essential. Advocate more for accelerate approval of new and advanced effective innovative therapies. The law has to be changed in favor of patients who suffer. In ASCAT, in my association in Barcelona, we published in Spain and in Catalan. Last year, we published an article about hepatitis D patients' testimonials with 10 patients. We have this article with the perspective of patients and also the opinion of the experts, the clinician, who was Dr. Maria Buti, and the laboratory expert, who was Dr. Francisco Rodriguez Frias. And also in ASCAT, we sent an informative note to our associates diagnosed with hepatitis B to make them aware that it is necessary to ensure whether or not they have hepatitis delta, so that their doctor, in case he does not know it, can carry out an analysis. Because in some cases, the doctors have done this analysis and perhaps it's negative, but perhaps this is not done in that time without no treatment. Next. Thank you very much.
Thank you so much, Dr. Casanovas. That was an excellent presentation and great overview from the patient perspective. So now we just have about 10 minutes left, but I think a lot of the questions that we were going to kind of discuss as a panel were covered in your excellent presentation. So just as an overview, I think some of the biggest challenges that were mentioned regarding especially diagnostics and treatment are the need for free testing and access to free medication, the availability of Bulevirtide and other drugs in general, reflex testing, shortening the time to approval of medication, improving screening to get accurate prevalence, which in turn increases support standardizing guidelines and the need for point of care testing, which I know I think Dr. Stefan Urban is making advances in that as well, who is the creator of Bulevirtide. So that will hopefully be coming soon. And then improvements in RNA testing as well. And I know Dr. Casanovas mentioned a lot about the need for equity and transparency for the available of new drugs and the importance of education of both providers and patients about hepatitis delta, which is greatly lacking. So I just wanted to take these last few minutes if there are anything else that you would like to share that has been a barrier that either still exists for hepatitis delta in your location or one that you've successfully overcome, and what kind of facilitates making life particularly for someone living with hepatitis delta, what has made it easier and what is still needed to improve life for people living with this disease in the coming years. So yes, Dr. Sella, feel free to go ahead.
Yes, I think to encourage to increase screening, diagnosis, linkage to care, when you have no treatment option in the past. I think now with treatment options, we need to reinforce all this message about test and treat, screening, diagnose, etc. I think when we screen and diagnose and we do not propose anything, it was very difficult to implement all this. So I think that now we have we have this treatment option, there's research, so we should work all together to improve all this.
Can I make a comment also?
Please.
Again, I agree with Tariq, what he said now, what he said before. You know, please remember, this is a rare disease, but it's not an easy disease. It's difficult to make diagnosis, it's difficult to make staging, you know. Antiviral therapy is not one pill for a couple of weeks and then you will be cured. Tariq mentioned, Adam mentioned, it's probably a long-term therapy. Maybe some patient can be cured on monotherapy. Mostly we might require different strategies, interferon or something else. So this is not an easy treatment. It's sub-Q injections. It's not a pill. Compliance, adherence, you know. So my point is that I think for this disease, the role of the reference center, the expert centers, is really crucial. So linkage to care, yes, but linkage to care to academic or expert centers, and please make sure the patients are managed by really expert centers and not managed by local hospital. They might have not access to new drugs, they have no access to new technologies, no access to everything. It's like hepatocellular carcinoma. We try to manage, as Tariq mentioned, at the level of a multidisciplinary team where you should be managed only in the centers that can provide you everything. You know, and today many new drugs will be available. Hopefully, we did not mention all the new studies some of the studies that will be presented at EASL, some of the new protocols that are starting across the globe. So it's a very important point. Once you have someone positive, don't manage right away, send to expert center, and they will manage for you in the top level.
Yeah, I think that's a very important point about the deeply complicated nature of this virus and of hepatitis B as well. Dr. Matthews, I think you had raised your hand.
Yeah, thank you. So I would wholly endorse what's just been said, and I think that represents very well the clinical and diagnostic end of the problem. Just to come in on the patient end of the problem, which Dr. Casanovas has already mentioned to some extent, but we're also really interested in providing better peer support, representation, advocacy, materials in the right language, and providing the right information for our patients. And I think really important to emphasize this when we've acknowledged that this is a kind of rare or orphan disease, and therefore people living with hepatitis delta might not have good access to education, resources, support, information. And it's important all the time, but it's particularly important at times when we've got new opportunities to offer potentially better treatments. But as has been said, it's a potentially long and complicated or at least it's a treatment journey, and that we have to sort of recognize and try and provide better peer support, but also, support across the board, social and medical support for patients who are going to be going through this journey.
Absolutely. I think the importance of holistic care and treating whole people is absolutely crucial with this. So thank you so much. Dr. Casanovas, please feel free to go ahead.
Thank you. Yes, I agree totally with this advice from Dr. Lambertico and also the experience of Dr. Asela. We have to implement treatment options and to offer perhaps combination treatment, not only Bulevirtide. And the clinical situation of each case should be managed for this team in a reference center with experience, with liver transplant perhaps, and teams with people very skilled doing ultrasonography, for example. Perhaps they will need a liver biopsy, because sometimes some patients' associations are totally against doing liver biopsy, and this is not the case, because this is special, because the non-invasive diagnosis methods are not totally validated for Delta. And perhaps we have a very young population or very old population, and also we need the liver biopsy and to send the patient in the experimented center with much better treatment options and management and explanation. And also agree totally that patients need information. And because we have immigrants coming from different countries with different culture and languages, and even the social status with a lot of barriers, not only cultural, but also economic and social, and barriers and stigma, because liver disease has also stigma. So we have to be comprehensive in these programs and to take into account the point of view of the liver patients.
Absolutely. Thank you so much for that point, and especially for bringing up, and the need for culturally and linguistically appropriate health education as well, and for stigma, which is very important in all hepatitis, I think. So thank you for that point. And Dr. Gerlan, I will pass it to you for the final comment. Thank you.
Thank you very much. I completely agree with my previous speakers. And I want to inform you that in Romania, we are planning to implement in parallel with the availability of Bulevirtide patient support program with the help of the producer of Bulevirtide, of course, and with some financial support, with some specially dedicated companies, firms, people that are going to help the patient to overcome the difficulties of this treatment, because it will be a long-term treatment. As my colleague said, it will be a treatment that will probably have problems with the adherence, with compliance of the patients. So they are the same firms that helped us in the past with implementing the hepatitis C treatments, and they did a good work. So we are going to keep this model and implement a patient support program. Okay, thank you very much.
That's wonderful news. I'm so glad to hear that. And I know, a lot of work has definitely been done around hepatitis C. So it's important to take models from that. So wonderful. Well, thank you all so much. Kara, would you mind just sharing the last slide, please? Thank you so much. So we really, really appreciate all of our panelists, and thank you so much to everyone for participating in today's webinar. I think it was a really robust discussion, and we hope that you were able to find it informative and valuable to your work or your life and apply some of the information going forward. Just some closing notes. So we encourage everyone to complete the evaluation form when the webinar concludes. And again, a recording of the webinar will be emailed out to all attendees and registrants. We also encourage you to sign up for our Hepatitis Delta newsletters for both providers and those who are living with Hepatitis Delta. I will put the links in the chat. In order to be added to our mailing list, we try to include regular updates about Hepatitis Delta drug development, clinical trials, research, and news, including events such as this one. So we encourage you to sign up for those. And also just a note that this is part 1 of a part 2 webinar. The second part, which will focus on Hepatitis Delta in parts of the world where Bulevirtide has not yet been approved, will take place 1 week from today on Thursday, June 15th at the same time. And the link to register, as well as the links for the newsletters, will be emailed out to everyone. And please do feel free to reach out to us and be in touch using the contact information on the slide, and to visit our website, hepdconnect.org, for more information. So thank you so much again to everyone for joining, and to all of our panelists. We really appreciate your time and insights. And yes, thank you so much. I hope you have a wonderful rest of the day.
Thank you. Thank you.
Thank you.
Thank
Bye-bye.
you.
Take care.
Bye.
Bye-bye.
Bye. Bye. Bye.
Bye.
Bye.